Part 3. Schizophrenia and Depression. This video covers neurotransmitter dysfunction in schizophrenia and depression.
Schizophrenia symptoms include psychotic or positive symptoms, such as episodes, delusions, paranoia, hallucinations, thought disorders, and disorganized thinking. This affects the mesolimbic dopamine pathway by increasing it in the nucleus accumbens. There is also deficit or negative symptoms, which disturbs motivation, social interaction, speech, and mood. This is affected by decreased dopamine in the prefrontal cortex, or the mesocortical pathway. Cognitive impairment or chronic impairment also occurs, which affects intellectual ability, memory, attention, and executive function, causing problems.
In schizophrenia, 4 neurotransmitters were found to be involved, which includes dopamine that regulates and increases in the nucleus accumbens, especially at D2 receptors, and decreases in the prefrontal cortex. Also, serotonin is dysfunctional in the prefrontal cortex. Glutamate in receptors where antagonism causes psychosis, and GABA is deficient in the prefrontal cortex as well. As a result of different neurotransmitters being influenced or affected, this causes different symptoms and effects. Dopamine produces positive symptoms, which, when increased in the nucleus accumbens, but cognitive and negative deficits like hypofrontality decreases cerebral blood flow in the prefrontal cortex.
Dopamine may be acting very strange in people with schizophrenia due to the fact that they may have too many D2 receptors.
Serotonin and GABA produces cognitive and negative symptoms, while glutamate produces psychosis when reduced. Pharmacotherapies include antipsychotics that work on dopamine. There are first-generation antipsychotics, which are not specific and produce major side effects. Second-generation antipsychotics act on the dopamine system by antagonizing D2 receptors. Third-generation antipsychotics partially antagonize D2 receptors and also 5-HT2A or serotonin antagonists. The problem with second-generation antipsychotics is that it doesn't treat negative or cognitive symptoms, only the positive ones, and further antagonizes D1 receptors, which causes side effects like acute dystonia, Parkinson's-like symptoms, and tardive dyskinesia.
There are issues in blocking dopamine receptors. D1 receptors are important for normal movement. The substantia nigra has dopamine, which is involved in movement, especially in the caudate nucleus, which decreases dopamine, produces Parkinson's-like symptoms. And blocking both D1 and D2 receptors stop the ability to move properly. Extrapyramidal side effects, or EPS, are the name for Parkinson's-like symptoms, which have reduced dopamine transmission. L-DOPA is used to treat Parkinson's by producing more dopamine. 80% of D2 receptors need to be blocked for antipsychotics to work. However, it has the add-on effect of also blocking D1 receptors. An extra side note, the difference between pyramidal versus extrapyramidal movement. Pyramidal movement is affected by primary motor cortex M1, the premotor area, and the supplementary motor area. This goes to the spinal cord and muscles, and it is responsible for voluntary movement. The extrapyramidal movements are affected by the nigrostriatal dopamine, or substantia nigra, which goes towards the caudate or basal ganglia, and this is in charge of rhythmicity and phasic movement, which is subconscious movement like walking. Blocking D1 thus influences walking and it producing Parkinson's-like symptoms.
Additionally, we will discuss the neurochemistry of depression.
Symptoms of depression include low mood state, a loss of interest, sleep disorders, low energy level, guilt, worthlessness, and less attention, as well as anxiety and suicidal thoughts. It is a major affective disorder.
The monoamine hypothesis of depression states that the depletion of monoamines is to blame for causing depression, being affected by serotonin, adrenaline, and then dopamine.
Evidence for the monoamine theory of depression includes the effectiveness of monoamine oxidase inhibitors in elevating the mood of depressed patients, the depletion of tryptophan, which is essential in serotonin creation. This produces symptoms of depression, the brains of suicide victims having less levels of serotonin, and the hippocampus, amygdala, and prefrontal cortex being affected by these monoamines.
Pharmacotherapies used to treat depression include first-generation antidepressants like tricyclic antidepressants or TCAs, which stop reuptake of all monoamines, and monoamine oxidase inhibitors, or MAOIs, or MAOIs, which stop metabolizing all monoamines. Second-generation antidepressants include selective serotonin reuptake inhibitors, SSRIs, noradrenaline reuptake inhibitors, NRIs, and serotonin noradrenaline reuptake inhibitors, SNRIs. These are more selective, blocking specific transporters, and thus have less side effects. Finally, there are agomelatine, which is a third-generation antidepressant used on melatonin receptors as an agonist, and serotonin in 2C and B antagonists.
Additionally, on tricyclic antidepressants, impramine or amitriptyline side effects include sympathetic or antimuscarinic symptoms like dry mouth, impaired vision, difficulty to urinate, impairment to learning and memory, and increased heart rate. It is also an antihistamine which produces sedation. It blocks alpha-1 adrenoreceptors, which affects the periphery, and postural hypotension, which lowers blood pressure when standing, causing one to faint. Cardiotoxic symptoms are also found here because it blocks the heart's ability to pump blood, and 25% of depressed patients overdose on TCAs, and another 15% commit suicide.
Therefore, we covered the theories that were believed to have caused schizophrenia and depression, the effects on certain neuroanatomical structures, and the neurochemistry, as well as the pharmacotherapies used to treat these issues. Thanks for watching.